Good afternoon. I'd like to welcome you all to today's webinar on short-stay rehab in the greenhouse model, a case study. My name is Scott Brown. I'm a director at the Greenhouse Project. As many of you know, the greenhouse model was originally conceived as a long-term care solution. The idea was to create real homes for elders that would enable them to live with dignity and achieve fulfilled, meaningful lives and live there through the remainder of their life. And right now there are many elders that are experiencing this type of a lifestyle. As we all know, however, being able to achieve a positive payer mix that includes Medicare dollars is critical to the financial viability of any skilled nursing organization. So in this webinar, we'll discuss how short-term rehab is delivered in the greenhouse homes. You're going to learn not only that it is possible to deliver short-term rehab in greenhouse homes, you can actually provide the kind of high-quality outcomes that make you a preferred provider for referral partners in an environment that's highly attractive for consumers. With that, what I'd like to do is introduce our presenters from the Leonard Florence Center for Living, Ina Hoffman and Jill Tura.
Good afternoon.
Hello.
I'm Ina.
And I'm Jill.
And we're going to take the next couple minutes or so to talk with you about short-term rehab at the Leonard Florence Center, how we got started with short-term rehab, what our goals are, and what our outcome has been because of our short-term rehab. At this point, I want to give you a little overview of the Leonard Florence Center. The Leonard Florence Center opened in 2009, February. We just had our 5th anniversary. We were the first urban greenhouse in the country. And what that meant was being in Chelsea, which is right next to Boston, we didn't have a lot of room to build single-family greenhouse homes. And so what we presented was to build one very large building and offer 10 greenhouse homes in that building. And that's what we have. We have 10 homes. Each of our homes has 10 residents. And our building is a little different than most other greenhouse models because in addition to our 5 elder homes, which we have, we also have 3 short-term rehab homes that we're going to talk about. And in addition to that, we have 2 specialty homes. We have one for MS residents, and we also have one for ALS residents. We are the first ALS house in the country. And with that, we have several people living here on ventilators. So when this idea was being presented, we knew that we needed to come up with some type of financial situation that would give us the opportunity to meet our mission of taking care of the elderly and disabled, the frail elderly and disabled, and those who really needed the most care, and to do it in a way that we would be able to offer Medicaid to so many of our residents here, and yet meet their needs through financial payment. So that is one of the reasons that we came up with 3 short-term residences because we felt it would balance our building. We started with one about 2 months after we opened the building, and since that time we've grown from the 1 short-term resident to 3, and we have approximately 30 Medicare or short-term residents at any given time. This did not happen overnight. We needed to do marketing and build up a referral source. We did that in the first year or so by going to meet with case managers. We offered programs that we could bring to the hospitals to talk about the greenhouse model, to talk about short-term rehab, and why people in the greenhouse model would benefit from their rehab. We got to know the case managers, and more importantly, they got to know us. We also had referral sources from some of our elder residents who were moving, and their children were spreading the word. Eventually, we became a provider of choice. The greenhouse has helped with that because there are not many places around that can offer what we do. We have the opportunity to have our private rooms. We also have the opportunity to have the meals right in the homes. And also very important, we have an amazing rehab department, which you will hear about from Joe very shortly. Who are our customers? We have really attracted a much younger population. We get many, many people who are having orthopedic surgery, and they have heard not only from the hospitals and from case managers who now know us, but it's really word of mouth. And we get a lot of repeats. We get a lot of children who came in to look for their parents and say, hey, I have to have this done. So they're coming to us. And our customers have completely changed from what they used to be. We have many, many younger people, and the goal is to get them in here. They do great rehab with our therapy staff, and the goal to get them out as quickly and as safely as we can. Who are our short-stay residents? The majority of our residents, our short-stay residents, are Medicare patients. Most of them are 65 and over because that's what Medicare usually starts at. However, there are many people who are disabled who are eligible for Medicare, and we get many, many people, younger people, who are on Medicare coming in here. I'd say that's about 90%, and 10% is commercial insurance. That being things like Blue Cross, Tufts. All of you have different commercial insurances in your area, and these would be the other commercial insurances. Our age range from 40s, we get a lot of younger people. Again, as I just mentioned, it could be because of the commercial insurance, or they're disabled and they're on Medicare. And our oldest patient was just recently, our oldest short-term resident was recently, and he's 106. So we run the gamut in this building. The majority, we have the advantage in being right next to Boston of having the amazing hospitals that we do. Again, it took a while to build up our reputation, not as an organization because people knew us as the Chelsea Jewish Foundation, but more as what is a greenhouse and why would I want to send my people needing rehab to you. But it has built up, and we get many, probably 70 to 75% of our short-term residents are coming from Mass General Hospital right now. We have many coming from the other major hospitals in Boston. We have many community hospitals. And then we have many people coming from acute rehab, such as Spalding, who still need more rehab, but they're not at that higher level. So many are coming that way. We get many people out of state because they are coming for the hospitals in our area. They're not ready to go home yet. So their loved ones might come here. They might even stay with friends or in a hotel while their loved one is rehabbing here. And our furthest has been from the Middle East. She was referred to us by the Mass General, and she has been with us twice. She needed to come in for orthopedic surgery, and both times she has come to us to rehab.
All right, so I'll talk a little bit about how the staffing works in our building and in our organization. In this building, our core therapy department consists of 3 physical therapists, 1 physical therapy assistant, 3 occupational therapists, and 1 occupational therapy assistant, and 1 full-time speech pathologist, in addition to myself, the rehab director. We try our best to use in-house staff as much as possible versus using contract staff. Actually, in the past year, we've cut back using our contract staff almost 100%. We know that using our own in-house staff is beneficial to our residents. It provides consistency and continuity. Our staff is available for staff trainings and meetings and family team meetings, and all of our in-house staff is trained in the greenhouse model. So they are familiar with all of the great things that the greenhouse model stands for. We have the benefit of being part of our organization's therapy company. We have our own therapy company. It's called Chelsea Jewish Therapy Services, and it's composed of all of the therapists that work in our building, the therapists that work for our home care agency, and the therapists that work in our other skilled nursing facility, in addition to a pretty large per diem pool. So our Chelsea Jewish Therapy Services is composed of close to 60 therapists, which has grown significantly in the years that I've been here. I've been here almost 5 years, and in that time we've gone from about, I would say, about 15 therapists to close to 60. So it's pretty significant. We have a large per diem pool. The therapists in the community know our reputation, and if they can't get in to be a full-time therapist here, they want to work per diem here. We have therapy. We provide therapy 7 days a week, 365 days a year, including weekends and holidays. Part of our obligation as a therapist within Chelsea Jewish Therapy Services is to work 1 weekend day a month and 2 holidays a year. So we always have staffing throughout our organization in this building on weekends and holidays. Great thing about this is a lot of times we'll have therapists that are working in our building on the weekends who work for our home care agency, and when our residents are ready to go home and transition to home, sometimes they go home with our home care agency, and a lot of times they'll have the same therapist that they've had here on the weekends and holidays. So there's a lot of really great continuity there. So much so that a lot of our residents that are returning request therapists they've had. We have a really homey environment because of the way our building is set up, that the therapists get to know the residents very well, and the residents get to know the therapists very well, and they know that the therapists are going to work them pretty hard, but they develop rapport and they develop relationships, which keeps them coming back to us.
And I just want to mention that when we get calls, or when I get calls from the hospitals, this is a really big aspect of our therapy, is people want to make sure that they're getting therapy 7 days a week, and that we offer it 7 days a week. And it's very, very it's very important to the case managers to know that we're offering these services 7 days a week.
So here at the Leonard Florence Center, we provide functionally based rehab. Our goal, obviously, is to prepare residents and their families for the safest possible return home. And we do that by engaging in residential-based mobility and self-care training and education. We provide therapy in an actual home environment, whereas most therapists can only simulate a home environment. Here we are providing therapy in the home.
So, short-term rehab admissions and discharges. This can be a little daunting for people who don't understand our building. but we have built an amazing stream of rehab patients and residents coming in here, so that we average approximately 45 admissions a month. In 2014, we had 515 admissions, and I would say we had discharges of 514. So we ran pretty close to, our admissions and discharges. This has been happening for the past 3 years, so it didn't happen, thankfully it didn't happen right away, because we would not have been able to handle that amount. But it's something that we have built up over the years and keeps our building going, because it's one of the things that we find extremely important here is communication, and keeping the communication open between our clinical team, our social service team, our social workers, our rehab department. We all need to work together to make this flow very evenly, because we can't get tied up. But we do have, as I said, about over 500 for the past couple years. And you'll see here that we do home safety evaluations as necessary. We don't have to do this with everyone. We have many people who are cut and dry. They come in, they get their rehab, and they go home. But then we also run into people that are questionable as whether this is going to be safe for them to go home. They might be a little older. We want to find out that they don't have any rugs on the floor, that they might trip over. Sometimes the children are afraid to send their parents home without a home safety evaluation. So how this works, we usually have our occupational therapist and our physical therapist go over to the home with the resident that's going to be going to their home, and usually it's a couple days before discharge, and our staff basically goes into the house to make sure that they have whatever they need to make it a safe home discharge, whether it means pulling up rugs, moving furniture, putting up grab bars, checking the shower, getting a shower chair. All these things is part of the home safety eval to make sure that person is safe to go home. And I would say 98% of the time they are. We do get that 2% where we just don't feel it's a safe discharge.
Okay, so our current case mix is comprised of about 50% orthopedics, hip fractures, knee fractures, spine surgeries. Right now we have 13% of our rehab folks are here for cardiopulmonary issues, congestive heart failure, COPD. 6% are currently neuro patients, and 31% are medical reasons, UTI, vertigo, falls. This is pretty representative of our typical case mix. I would say that our medical right now is a little bit high and our cardiopulmonary is a little bit low, but it's pretty representative of our typical case mix. As you can see, almost half of our rehab folks are here for ortho reasons. They're, as Ina had talked a little bit earlier, we're getting a lot of younger folks who are here for hip fractures or knee replacements, hip replacements, things like that. And they're choosing us over acute rehab hospitals such as Spalding Rehab, which is pretty significant. We have the private rooms with the private bathrooms. It's pretty great, and we have a really good reputation. So all of these younger ortho folks are coming to work with us.
The harder one, and just to jump in here, and Jill won't say too much on this. We get a lot of people who have strokes, which is a CVA. Mm-hmm. And, these we know are going to take longer than a healthy person coming in, had a total knee done, needs to get their rehab, needs to get through the pain, and then they go home. CVAs are, strokes are a little more difficult. We have an amazing team of therapists who work with them. We've talked about physical therapy and we've talked about occupational therapy, but we also have speech and language. And we have a wonderful young woman who works with our stroke patients, whether they need some cognitive therapy to get back some of their memory, whether they need it for speech, whatever it might be. So they actually are getting 3 different types of therapy when they come here. And it's extremely important, and I believe that we have built a good team here and that the hospitals know that they can call on us for this. Anything else on this? And again, one of the reasons people are wanting to come here is because of the private rooms that we offer, and also because of the kitchens being right there. Many people have to watch their diets. It's much easier to do right here in the home, that our staff know about this person. They know they might be on a limited diet, and they can watch it a lot easier than having it go through a big dining room and not having the same individualization as you find in the greenhouse model.
So in our building, we provide functional rehab throughout the entire house and throughout the entire building, actually. We have access to the kitchens in each house. We have access to laundry, the living room, the bathrooms. Like I said a little bit earlier, most therapists can only simulate functional therapy, but here at the Leonard Florence Center, we can actually do practical therapy in an actual home. We can practice transfers from actual living room furniture. We can assess actual household distances if a person needs to be able to walk household distances. We can really see how a person maneuvers around a real home. It's really an occupational therapist's dream here because they really don't have to do much simulation. It's therapy in a real home. And this is really great because we can ensure that these folks are going to be going home safely. We know that they're able to maneuver around a real home. We know that they're able to do their own laundry and prepare food in a kitchen. We have 2, we call them, they're not really gyms, but they're dens that are, they're community rooms that we do have some rehab equipment that you might see in another rehab facility. We have a bike, we have some parallel bars, things that are really necessary to provide therapy, but it's not an overwhelming therapy gym like you might see elsewhere. We really do a lot of our therapy in the house setting. We do, the residents do the therapy in the home. They get to know the other residents in the house, and they really get to know each other and encourage each other when they see each other doing therapies. But then they also have the benefit of having their individual rooms with the individual bathrooms where they can practice doing their ADLs in privacy, where they don't have a roommate that is trying to get into the bathroom as they're working on dressing or showering or other ADLs. So it's really a great place to be doing practical therapy. We have everything that we need in a home situation.
And I just want to jump in here and say that sometimes I'll go into one of the gyms, and there will be a couple people that are working together with different therapists, and we're finding that they're encouraging each other. Somebody might have just had a knee replacement 3 days ago, and somebody had it a week ago, and that person a week ago is telling that person who's still trying to get through the pain of 3 days ago that, you're going to feel better and this is what's going to happen. And they really encourage each other. And that happens not only in the gyms, but certainly around the dining table. when they're having their meals.
Right.
And the socialization here has been great.
Yeah, they really get to know each other, and it really fosters a sense of family or community. A lot of times I'll see residents exchanging phone numbers at the table before one of them goes home because they want to keep in touch with each other in the community. So it's really a great environment to provide therapy. Okay, so how we get paid. A majority of our reimbursement comes from Medicare Part A and RUGS utilization. And RUGS is an acronym for Resource Utilization Groups. It's a classification system based on the amount and frequency of therapy that's provided, as well as an ADL index. So the levels, there's 4 levels. The very highest level is called an RU, or an ultra high. The next highest level is a rehab very high. And then the third highest level is high, and the lowest rehab level is a rehab medium. So depending on the amount of therapy that's provided and the frequency that's provided, it will classify a person into one of these levels. And then the amount of assistance that's necessary that's provided by the direct care staff will attach what we call an ADL index. So it's sort of a modifier that, tells us how much more assistance they need. So based on the level that the person is at, we are reimbursed a certain amount. So in our building in 2014, 79% of our rehab candidates, or 79% of our rehab days actually were in the ultra-high category, which is actually pretty high, pretty significant. And I think that's because, I think it's attributed a lot to the type of residents that we admit, those ortho patients that come in that are pretty straightforward. They're not very medically complicated. They come in, they're very motivated, they want to do their therapy, and they get all the minutes and they get all the therapy days. So I would say that high level of ultra-high candidates is due to the high-level patients that we get, high-level residents that we get. Down at the bottom, you can see that an average daily RU rate is about $600 per day, given an ADL index of a B. The ADL index is rated an A, B, C, depending on how much assistance the person needs with their ADLs. So this reimbursement really helps to meet our greenhouse goal because we're getting all of this reimbursement from our short-term residents that helps keep our elders in the long-term residence happy and cared for.
And I just want to mention Jill's staff. They do an amazing job, and they've been called many names sometimes by some of our rehab candidates that come in, but they do an amazing job of getting them back to their functional level prior to their coming into the Leonard Florence Center for their rehab, whether it be their spine or a stroke or a hip or a knee. Her rehab staff really works with them and can be very strict to make sure that that person is meeting their goals. So I'm going to talk briefly about our nursing and Shabazim staffing for the short-term rehab. We have in the hospitals 2 nurse liaisons. They're both registered nurses. One is in one particular hospital, which is Mass General Hospital, because as I mentioned before, we have our greatest percentage of rehab residents coming from that hospital. And so we have one nurse liaison who is at that hospital all the time. We have another nurse liaison who travels around to different hospitals or acute centers to make sure that the candidates that were coming in are the best possible candidates for our short-term rehab houses. They really are our eyes and ears out in the community. And they are the people that they're our marketing people in the hospitals. They're representing us. They go to see the person who needs the rehab. They can answer any questions they might have. They might meet with the children. And they're really the eyes and ears, as I mentioned. In the homes, we have our nurse, either an RN or an LPN. We have one nurse on each floor. Our homes are divided, our floors are divided so that our third, fourth, and fifth floors are exactly the same. We have one short-term rehab house on one side of the elevator. On the other side, we have an elder home. And this gives our nurse the opportunity to really know we have the same staffing in those homes so that the nurse really knows our elders and what their rhythm of the day is. And then she can stay in touch and stay at the pace of what we have with our admissions and discharges. So she is, he or she is there to do that. Those are our RNs and LPNs. We also have two nurse mentors, and they're both they work throughout the building, and they work with the clinical team to make sure that all the residents' needs are being met. It could be that they're helping with the admissions that are coming in that day. They might be helping the nurse answer questions. They might be making sure that all the respective appointments that might need to be done have been taken care of. So their role is very mixed, but very important in this building. So those are our nurse mentors, and as I mentioned, we have two, and they both work basically from 7:30 in the morning till about 4 o'clock at the end of the day. So those are our nurse mentors. We also have another mentor who comes in on the 3 to 11 time, and he also will help with admissions, with any questions that the nurses on the floors might have. Those are our nurse mentors. And then we have our two shabazim who are in the house, in the short-term rehab houses. On the overnight, there is always one in the home. And what we find with the shabazim that need to work in those homes is their flexibility. The shabazim have to have some type of flexibility to keep up with the pace that we have. You know, honestly, it would be easier for them in a long-term home with our elders because they really get to know them. But here it's a much faster pace. And they do have to kind of keep up with all the rehab patients that are coming in. And sometimes our rehab patients, when they first come in, aren't feeling that well. They've just had surgery maybe 3 days ago. And these shabazim really have to act, and really as the shabaz overseeing to make sure that everything is going well in that home. So one thing that has come up in the past couple of years that honestly when we started our rehab wasn't as significant to us as it is today is an accountable care organization, or ACOs. And I'm going to talk briefly about an ACO and how they're impacting the short-term, the SNFs, the skilled nursing facilities. What is an ACO? An accountable care organization is a group of doctors, hospitals, and other healthcare providers who come together voluntarily to give coordinated, quality care to the Medicare patients they are serving. The goal of an accountable care organization is to keep the people healthy, keep the costs down, and avoid hospitalizations. And with that, one way of keeping costs down is to making sure that we're all on the same page. with the hospital, with the other healthcare providers involved, and keeping the length of stay down, because this is going to be helpful to everyone. And they have to be accountable. And by that, we're saying that if they do a good job with the Medicare patient and they stay healthy, they keep the length of stay down, they stay out of the hospital, this accountable care organization will be given a reimbursement for keeping this person healthy. At the Leonard Florence Center, ACOs are important to us because we have been partnering with two of the major hospitals, or actually three of the major hospitals in our area, BI and Partners Health, which is extremely big in this area, by communicating with them on a weekly basis. We have been part of pilot programs in both areas, talking with them. There is what's known as a waiver program now, where Medicare will give certain patients at the hospital, high-risk patients, leeway not to stay in the hospital 3 nights because they really don't need it. They just need to get over to a skilled facility, get some rehab. And so there have been some pilot programs for this in which we have been involved, and we get several waiver patients from the hospitals. And what that does, it gives us an opportunity to work with the hospitals either on a weekly basis, on a bi-weekly basis, just calling up that case manager who might be following that patient, giving them an update, make sure that the certain doctor's appointment they might need has been made. But we work together in order to keep that person as healthy as possible in the shortest amount of time they need to be at our place at the Leonard Florence Center. The impact of the ACO on a short-term rehab, it's a coordinated, efficient transition of care. We need to work together. We work together to keep the length of stay down. We work together to make sure that that person is getting the functional rehab that they need. We're keeping the rehospitalization down. This is very important for everyone because we don't want to see someone go home and then wind up in the hospital 2 days later. And along with that is keeping the family and the patient and that short-term rehab resident satisfied. And with that, I'll go into the next slide, which is how we're doing. We have had the opportunity to partner with the greenhouse model with my interview, which is an evaluation of rehab and elders, to talk about how we're doing and to evaluate us. And the advantage of my interview is that it's an opportunity for us to compare ourselves nationally. So that's what we do on a national level. And on a community level, we send out surveys. And once a short-term resident leaves here, we have a survey where they can answer questions about each part of their service here, whether it be admissions process, rehab, social services, nursing, and overall evaluation of their stay at the Leonard Florence Center. And what I did, on it, we asked, would you come back here? And 99.9 say yes. And you're always going to get somebody that's not always happy with you. And then these are some of the comments that I've put down. And this is from our rehab residents. The setting is like a home. They felt like best friends. They were very comfortable. And at this point, I just want to mention, as Jill did, about people exchanging phone numbers. And because of the large amount of admissions and discharges we have every day, we ask people to be discharged about 11 o'clock in the morning, but we run into a little issue with this because we have many, many people who won't leave until they have that last lunch with their new friends. So many times they're not leaving till 1 o'clock. Another resident has written that the small group atmosphere has caused this good bonding, and we know that happens. Not only does it happen in our elder homes, but it can happen very quickly with our rehab residents. Everyone is exceptional, kind, compassionate. Just like anywhere else, the greenhouse model always tries to get the kindest, caring people to work in their organization, and we're no different with that. The Leonard Florence Center makes everyone feel like family, and we certainly try and do that. And the atmosphere, the caring workers, and the cleanliness have all contributed to their positive stay at the Leonard Florence Center. What we have learned regarding admissions, we never want to get away from the mission of our building, of our organization, to take care of the frail, elderly, and in our case, the disabled, the ones who need us the most. We have found that team decision-making and a common vision amongst all our staff and across the board, rehab, nursing, social services, admission, administration, we all have to work together. A reputation takes time to build. We started with a wonderful organization, the Chelsea Jewish Foundation. It's been around our community since 1918. So we got off to a good start. But nobody knew what a greenhouse was when we started. And certainly when we would go to the case managers in the hospital or elder care attorneys or geriatric care managers, it took time to build our reputation. But that certainly has happened. And follow-up as a means of customer service. We always try, as I mentioned, with our evaluations. We also follow up afterward. We always try and stay in touch within the first couple weeks of residents going home to their own homes. We always do follow-up phone calls to make sure everything is going well. And we also have the opportunity with many of our short-term residents, as I mentioned, to have the communication with the hospitals and the case managers. So at that point, I think Jill and I want to thank you and answer any questions you might have. Okay, I guess we're getting, okay. Have you ever tried a house mixed with a half long-term care and half short-term? No. What? We really try not to do that. Once in a while, we don't have any availability, and we've had to maybe put a long-term person in a short-term rehab until something opens up, but we really try not to do that. Our average length of stay?
Our average length of stay right now, I think, is about 18 days for our rehab folks. We talked a little bit about with the ACOs, our focus right now is kind of trying to reduce that length of stay a little bit, but I think 18 or 19 is our average length currently.
And the next question is, working with ACOs, do you still get paid full RUG rates?
Yes.
Yes, we do.
Yep.
Yes. How is your facility certified? Are the rooms paid for privately? Well, we're certified as a skilled nursing facility with 100 Medicare certified beds, if that's the question.
What do you mean by like JACO?
Yeah, and we're also JACO certified. I don't know. Duly certified Medicare, Medicaid, yes. All of our beds are duly certified. And do you have one nurse for each? No, we do not have one nurse for each short-term house. We have one nurse who goes between the two houses on that floor. So it's really 1 for 20. But as I explained before, we have one of our elder homes right across the hall, and so it works out very well. What is your hospital readmission rate? We have a very low readmission rate within 30 days.
I don't have an actual number, but it's not very high. Pretty low.
It's very low. I think 9% is the average, but we certainly are nowhere near that. Could you please address your mix of local patients versus patient need from other states? The greatest percentage, obviously, is going to be right here of our local patients that are here. But as I mentioned before, because of the hospitals we have in our area, we have many people coming from out of state so they can have surgeries or procedures in our area. And then we are referred by the case managers and the hospitals to come here for their rehab. The next question is the number of shabazim for the rehab house 3 or 4 during the days? No, not usually at all.
There's 2 per house during the day.
Yeah, and it works out well. And don't forget, a lot of our rehab staff are in the house during the day working with the people getting their rehab. So they're always available also. The next question is, do you have difficulty getting private insurances to pay for therapy 7 days a week? Usually with private insurances, they're going to give you a set amount. They're not really going to say, well, we'll give you X amount of money if you give 7 days. They give us X amount of money, and it's up to us to offer the best therapy, which we do at any rate. And as Jill mentioned about the rug rates, we might be more on a level basis with some of the insurances that come in, but we still work to make sure that they're getting the same amount of rehab and to get them home as quickly and as safely as possible.
Okay, the next question says, we only provide therapy 6 days a week because we have a hard time getting our residents to agree to do therapy on Sundays. Thoughts? You're always going to have residents that will give you, will have a hard time doing therapy every day, but like I talked about before, a lot of our residents are here for ortho surgeries. They're younger residents. They're really motivated to do therapy. So we don't really run into that problem a lot. It happens occasionally. In addition to holidays, sometimes residents don't want to do therapy on holidays, and you know, our therapists work with them pretty regularly so that they get to know the residents, and the residents will usually say, you know, I would prefer not to have therapy on Sunday for religious purposes, or I would prefer not to do therapy on Thanksgiving because I'm going out with my family members. So, you know, we recognize that, we work around it, and we just we just work around it.
Okay, the next question is there a room for the Shabazz overnight? What do they do when residents are asleep? There is no room that is available overnight for the Shabazz other than where they're supposed to be staying, which is in the living room, in the dining area, in the kitchen area, so that they can help our residents. That is their goal when they're in that house. They are not supposed to be sleeping. They are supposed to be taking care of the residents. And don't forget, there are residents who have just come from the hospital. They might be in pain because they had surgery. We have to make sure that our Shabazz are available overnight to help them with whatever need they have. The next question is, do you compete with hospital-owned short-stay facilities? And I would have to say, yes, we do. We have many of our larger organizations in the area, hospitals, who have their own short-stay facilities. And, yes, they do refer to their facilities. However, the residents have a choice of where they want to go, and many times they will say, no, I don't want to go to X, Y, and Z rehab, I want to go to the Leonard Florence Center because I want my own room, or because they have great rehab, or I love the greenhouse model. So yes, we do, but not necessarily that everyone will go to their respective hospital-owned short stay. Do Shabazim and short-term care homes have a higher pay scale? I don't think so. I can't answer that. I know that we try and pay our Shabazim at a good pay scale here. They work hard, just like yours do. But I don't think they're at a higher pay scale. If I find out differently, Sheila, I can let you know that, and I can ask Rachel for your email. The next question.
Do you feel that a continuation of outpatient therapy services would be beneficial to help with continuum of care? Certainly a lot of our folks that leave here, we do recommend continued therapy either through a home care agency or in an outpatient clinic. The benefit of going right to a home care agency would be the residents would have the ability to have access to home health aides and nursing services, whereas if they went directly to an outpatient service, they wouldn't be eligible for those types of other services. But some do leave and go directly to an outpatient therapy program. It happens not very regularly, but occasionally.
And one thing I do want to mention here, we always have a discharge planning meeting with that rehab resident. So involved in that is our social worker. Sometimes a nurse will be there if it's needed, and definitely our rehab staff, because they're the ones that really know how that person has done through their therapy. We always arrange therapy services or home care services for them when they leave. I would say 99% of the people who leave here need to have some type of continual therapy services or home care services when they go home. Usually occupational therapy, physical therapy, and nursing. Sometimes a home health aide if it's needed, and sometimes even speech if it's needed, depending on the needs of that person going home. The next question is, do you find the need for recliners in short term? If so, how many per home? Yeah, sometimes we do. There are some people that have come in, and some people don't sleep in a bed. Some people sleep in chairs. So we do have some that are available in the building. I wouldn't say how many per home because it's not really per home. We have them a couple in the building.
2 or 3 in the building?
Yeah, 2 or 3 in the building.
Okay, the next question is, thank you for sharing your payer mix, RU rate, etc. Can you comment on how this compares to your competition? This is significantly or only moderately higher reimbursements than medical models short-term rehab. So I think that our utilization rate is in about the 90th percentile of the facilities in our area. I think it is a pretty high utilization for the ultra high reimbursement. I can't speak to exactly how much higher it is than a medical model short-term rehab, but it is pretty high. I know that. Okay.
Next question is, I am from John Knox Village, a greenhouse project in Florida. Do you have copies of surveys mailed locally after discharge? Yes, we always get those surveys back, and that's how we know how we're doing. And what we do at our quality assurance meetings on a quarterly basis, we tally them, so we know how we're doing, and we also can talk about what needs to be, what's working, what's not working, and what we can do to make it better. So yes, we have all those. The next question is, how are your surveyors, and do they find the survey process different? Our surveyors, the first couple of times, were very overwhelmed. They came into our building, and not only did they have one kitchen, they actually had 11 kitchens to survey. but they've gotten used to it now because we've had it now. This is our 5th year. Is it different? No, I think we still have to meet all the needs of our state. You know, just because we are the first greenhouse home in the state of Massachusetts doesn't mean that we have to do anything differently as far as meeting the needs of our state surveyors.
Except maybe explain a little bit more.
Yeah, right. Explaining more of what we do and why we do it.
All right. The next question is, do you offer modalities? We do offer modalities. We don't utilize them a lot. Currently, I believe we have one person on caseload that is using TENS for pain management, but we do have ultrasound and e-stim and all that available if we need to use it.
Are there any other questions? Do you have overbed tables available for short term? We do. We find that necessary for our residents because, especially, we're getting a lot of younger people. They have their own computers that they're bringing in, and they want them right in front of them. So yes, we do. The other thing that's really...
Go ahead.
Okay, no, go ahead. I'm done.
Well, I was going to say that we were about at 2 o'clock, and so I wanted to wrap up. Is there a last question or comment?
Hello?
Yes.
Hi, this is Barbara Cuff from John Knox Village. I'm apologizing. I was only able to join by audio. I had a couple quick questions. You gave us your average length of stay. Do you have a different length of stay for your neuro patients?
No, we
okay.
don't.
That 18 to 19 day then. Okay.
No, it's usually I would say, if I could give an average, I would say maybe like 1 to 2 months, somewhere around there.
So 1 to 2 months. Okay. And
a little bit longer.
On your admits, do you oftentimes do a day one assessment, or do you? I mean, getting in there early during the day, is your staff able to see them on day of admission, or how do you normally work that?
A lot of our admissions come later in the evening. We do day one. We do eval day one as we're able to. If I know ahead of time if we're going to have somebody in the building earlier in the day, we can certainly do day one admissions. Typically, I would say 75% of our evaluations are done on day 2, and that's really just because the majority of our admissions come later in the evening, around supper time and after supper time.
Okay. And do you run a therapy schedule? I mean, I know that we're not quite in ours yet. We're hoping we'll be ready to go by April of next year, but one of the things when we talk about marketing it, we say how nice it is, and you can get eggs at 10 o'clock, and you can get waffles at 9:30, and all these things. And then I look at it from a rehab standpoint and go, oh boy, how are we going to get these residents to rehab though? So
right.
I'm just wondering how those differ, because those floors have to be significantly different in my mind than the rest of them, and the pace of them, and the schedule.
Right. We run into that too. In addition, we have a salon that's down in our lobby area and a spa where the residents can go have facials and manicures. So sometimes the priority of the patient is not necessarily rehab, and unfortunately we just sort of work around that. We might utilize that as an opportunity to ambulate the resident down to the spa for their manicure, and then anticipate when they'll be done and ambulate them back. So that is, we do have a beautiful building, and the residents can have their breakfast whenever they want, and we run into that, but we work around it. The therapists are really good at advocating for therapy and telling the residents, why it's beneficial to be receiving their therapy. And then on the other hand, a lot of the residents that come in, therapy is their priority. So whenever it's time to do therapy, they do their therapy. So you have both sides of that.
And do you have what we're heading towards is that we will have a gym on the first floor next to our commons area and bistro and all that, which will also function for outpatient. But do you have a set place too? I know you do a lot of functional issues on the floor as we do currently in the setting that we're in now. But do you also have patients that you bring to that gym for the lower level things that you need to really work on?
We do have two dens, one in the third floor short-term house and one on the fifth floor short-term house that sort of function as a gym sometimes, the equipment that we do have. So we do have some, we have a bike and some parallel bars and a couple other things that we do utilize.
Okay. All right. Great. Thank you so much.
And we're happy. I know that our emails are on there, and if you have any other questions, please feel free to email either Jill or myself.
Great. Thank you.
So, Anna and Jill, looks like there's one last question from Al Beamer.
Okay. We don't have it.
Okay. It says, how do you handle the situation where the resident is too frail to do full rehab right out of the hospital? Start on clinical rugs and move in after a few days?
Yeah. Mm-hmm. Sure. We, if the resident isn't appropriate for therapy initially, we always do an evaluation when they come in. If they're not appropriate initially, we can always pick them up a couple days later. And we only provide therapy that's appropriate for that person's level of functioning. So we're not shooting for ultra-high categories on every resident that comes in. We're very cognizant of what a person is capable of doing, what they're able to do, and we work with them at that level.
Well, thank you, everyone. That will wrap it up for today. As Ina mentioned, the contact information for both Ina and Jill are on this last slide. If you have further questions, feel free to reach out to them. Thank you, and have a great day.
Thank you very much. Thank you, everyone.